here tonight to discuss the endocrine system and the musculoskeletal system because these are the two different systems that we are going off in class over. These are the two different systems that we are going over in class right now. I am currently in Med Surg 2, and I just decided that it will be a lot easier for me to come over and go over all of my notes and speak them out loudly instead of just like reading them over and over and pretty much pretend that I have my own class and my own audience. This is pretty much to, like I said, speak the information and lecture it all out as if I am the teacher, and this will help me drill the information in my head a lot better. Because as you all know, if you are in nursing school, nursing is very complex. It involves a lot of complex processes, a lot of different disease processes, a lot of different ways to approach things. There are a lot of different signs and symptoms that you have to watch for, lots of different patient educations, and we're going to get into all of that during this study guide right here. So a lot of the information that is not in order, it is a little bit based off of how my professor lectured it out during class. But I was able to jot down a lot of information, a lot of different things. So let's jump right into all of that. So what is the command center of the brain? Well, the command center of the brain is the hypothalamus. And who does the hypothalamus communicate to? The hypothalamus communicates to the pituitary gland. Now, there are two parts to the pituitary gland. And what are they? You have the anterior pituitary gland, and you have the posterior pituitary gland. Now, on the posterior pituitary gland, you have two hormones. The two different hormones on the posterior pituitary gland is ADH and oxytocin. Now, what are the functions of ADH and oxytocin? Well, the function of ADH is to reabsorb water. And the function of oxytocin is the love hormone. Oxytocin also stimulates contractions within the uterus, and it also stimulates the mammary gland to eject milk. Now, if a patient does not have enough ADH, what disorder might the patient have? They might have diabetes insipidus. Now, diabetes insipidus has nothing to do with diabetes mellitus, which is a condition of the pancreas. Diabetes insipidus is a condition of the kidneys and not having enough ADH. ADH is an antidiuretic hormone which helps you reabsorb all of the water. And if you don't have enough ADH, you are going to produce a copious amount of dilute urine. The patient will experience a profound diuresis, which is an excessive urination, and peeing up to 3 to 20 liters within a 24-hour period. The normal range should be between 800 and 2,000 milliliters, so like around 2 liters of urine based on normal fluid intake within a 24-hour period. So if you are urinating 3 to 20 liters of urine, that is way too much urine being excreted, and you are not retaining any fluids. This could also put you at risk for fluid volume deficit, which could also lead to dehydration because you are peeing out all of your fluids. Now, what is a medication that is used to fix this? A medication used to fix this is a synthetic form of ADH, which is desmopressin. Desmopressin is a synthetic ADH that replaces the insufficient amounts of naturally produced ADH. A doctor may order to increase fluids with this patient because you are losing a lot of fluids. So if you are losing a lot of fluids and your body is not reabsorbing it, you are going to want to increase the fluids to prevent fluid volume deficit, which is like dehydration and not having enough fluid. Hypovolemic is another word for hypovolemia. You also want to educate the patient to monitor their weight daily in order to monitor the intake and output of urine and how much fluid that they are excreting or retaining. So the opposite of diabetes insipidus is a condition known as syndrome of inappropriate antidiuretic hormone, also known as SIADH, the short version. SIADH consists of an excessive amount of ADH, which is resulting in fluid retention. So because you have too much ADH, which is reabsorbing water, you will end up resulting in fluid retention because of all of the water being absorbed. And when you have fluid retention, you end up in fluid volume excess, which is having way too much fluid. There is a medication to treat this, and it is known as tolvaptan, and the doctors also may order to restrict fluids. And the doctor is going to restrict fluids because you are already at fluid volume excess, also known as hypervolemia with SIADH, and you're not going to want to increase more fluids that are already not being excreted. So, hyperthyroidism is a disorder of an overactive thyroid. Cushing's is a disorder of too many steroids. Giantism in children and acromegaly is for adults is a disorder of overproduction of the growth hormone. An underactive thyroid. For an underactive thyroid, you would want to increase iodine in the diet. And the doctor would also order levothyroxine, also known as Synthroid. Now, if the patient continues to gain weight on levothyroxine, this may indicate that the medication dosage is too little. So, one of the symptoms of hypothyroidism is weight gain associated with an decreased appetite, but continuous weight gain. So, if you are on levothyroxine and you are continuously gaining weight, this could indicate that the medication is not enough and may need to be increased. So what is the hormone in the anterior pituitary that stimulates the adrenal cortex to produce steroids? This would be the ACTH hormone, which is the adrenocorticotropic hormone. That tells the adrenal cortex to release steroids, which are the mineralocorticoids and the glucocorticoids. The mineralocorticoids is the aldosterone, and the glucocorticoids is the body's natural cortisol. The aldosterone reabsorbs the sodium, and when you are reabsorbing sodium, puts you at risk for hypokalemia, which is losing potassium or not enough potassium. So the reason that this happens is because sodium and potassium works on like a balance scale. So when you have an excessive amount of sodium, you end up losing potassium. So when you have an excessive amount of potassium, you end up losing sodium. So they balance each other out on levels like a balance scale. So what should a patient never do when taking steroids, which are the glucocorticoids, which is the body's natural cortisol? So when taking steroids, it is very important to never abruptly stop taking steroids. Steroids must be tapered off if you're going to stop taking steroids. If this happens, the adrenal cortex is at risk for shutting down, which will stop the production of steroids, which are the mineralocorticoids, which is the aldosterone, and the glucocorticoids, which is the cortisol. And then this will increase blood glucose levels and inhibit inflammation and the immune response. We need our body's natural steroids to regulate these processes and these responses, which is why we cannot disrupt the adrenal cortex and why we should never start or stop abruptly taking steroids. So if you start steroids, you don't want to abruptly stop taking them because you then throw off the adrenal cortex, which is in charge of producing the body's natural steroids, which is the mineralocorticoids and the glucocorticoids for the aldosterone and the cortisol. And if you shut those down, which are in charge of the body's immune responses and inflammatory responses, you put the body at risk for not producing the steroids. So in order to not have that happen, you should taper the body off the steroids so that the body can slowly start to produce the natural steroids again on their own. Very important to never just abruptly stop taking steroids. What is the job of calcitonin? Calcitonin puts calcium back into the bone. Who puts the calcium back into the blood? This would be the parathyroid gland. If a patient ate a low-carb lunch, what would happen to the body's blood glucose? Well, initially, the blood glucose will increase, leading to hyperglycemia, to compensate for the lack of sugar intake. This won't last forever, and eventually they will become hypoglycemic. Pretty much the body is compensating for the lack of sugar intake by increasing the body's blood sugar to combat, any type of effects from low blood sugar. That won't happen forever, and eventually the body will go into hypoglycemia because of the decrease of sugar intake. But initially, to compensate that sugar, the body is going to raise the natural blood glucose. Three labs for the thyroid test. Okay, so the three labs for the thyroid test will be the T4, the T3, and the TSH. The ranges for the T4 would be 4.5 to 12. The ranges for the T3 will be 70 to 190. The ranges for the TSH will be 0.3 to 5. Couple important things you are going to want to consider as the nurse when giving thyroid tests. You're going to want to tell them to hold aspirin and hold anything with iodine, furosemide, phenytoin, and heparin. These are all things that can interfere with the T8, with the T4 and the T3 and the TSH levels of the thyroid. Osteomyelitis. Osteomyelitis is a bacterial infection of the bone. The bacteria responsible for the bacteria infection is Staphylococcus aureus. What you are going to see in the test for osteomyelitis would be bone destruction on a radiograph 7 to 10 days after the onset of the disease. If the thyroid is removed via thyroidectomy to get rid of hyperthyroidism, what should the nurse worry about? So if you remove the thyroid, think of the endocrine system as an opposite. If you are hyperthyroidism and you end up removing that, the opposite effect happens. And that happens with a lot of the different processes in the endocrine system. So if you remove the thyroid via thyroidectomy and you have hyperthyroidism, the opposite effect of hypothyroidism may end up occurring. The thyroid was removed for overactive thyroid. Once it removes, the opposite effect may occur because you no longer have a thyroid. The endocrine system is all about opposites. Now, if the patient starts to twitch after getting a thyroidectomy, the parathyroid may have been cut into and messed with the calcium levels within the blood, which could lead to hypocalcemia. This is when you're going to get like the Shevick sign of like the twitching and stuff like in the face, which is like the Shevick sign and muscle nerves in the face twitching. And you also have the Trousseau sign, which is like the carpal spasms and things of that happening. Those are signs that, the parathyroid has been cut into and the calcium levels have been messed with because the parathyroid puts the calcium into the blood and you mess with the parathyroid. Now calcium in the blood levels are being messed up. See how that, my professor was breaking this down, like I was just getting hyped. I'm just like, oh my God, like that actually makes sense. So, signs of underactive thyroid. So let's talk a little bit about hypothyroidism. Signs of underactive thyroid / hypothyroidism would be a decrease in appetite, weight gain, slow metabolism, hypothermia, which is cold, bradycardic, which is a slow heart rate, hypotensive, which is low blood pressure, hypoglycemic and diabetics, which is low blood sugar, depression, fatigue, dry skin, numbness, and tingling. Those are all signs of hypothyroidism, which is underactive thyroid. Levothyroxine, also known as Synthroid, may be prescribed in order to treat hypothyroidism. So some things about levothyroxine. When you are taking levothyroxine, you want to take levothyroxine on an empty stomach because medications and food can interfere with the absorption, especially those foods rich in iron, fiber, calcium, and soy. You want to take at the same time each day. The morning time is the recommended time to take Synthroid. You never stop abruptly. You also want to watch for signs for myxedema coma, which would be dizziness, respiratory distress, low blood sugar, or hypothermia. hyperthyroidism, which is the opposite of hypothyroidism, you're going to experience some of the opposite symptoms. So you're going to have things like weight loss due to an increased metabolic rate, high blood pressure, high pulse rate, increased temperature, being hot, they're being agitated. So like all of the opposite effects with hyperthyroidism versus hypothyroidism. With hyperthyroidism, we have a faster metabolic rate, which is causing the weight loss. We have the blood pressure increases, all body processes being elevated and being increased. Versus hypothyroidism, when you have underactive and a slower metabolic rate, which leads to the weight gain. And bradycardic, slow heart rate, and low blood pressure, and coldness, and things of that sort, because the processes are going down instead of up. So those are the differences between hypothyroidism and hyperthyroidism. Some medications to treat hyperthyroidism would be tapazole, also known as methotrexate. I believe I gotta look into my book to be for sure, but I know for sure that it is tapazole. And then you also have prothiouracil, which is also known as PTU. And you also have ablation therapy, which is radioactive iodine. Those are going to be like the 3 lines of medication that are going to be ordered in order to treat hyperthyroidism. The first one's going to be tapazole. Then we're going to go to prothiouracil, also known as PTU. And then we're going to look at ablation therapy. In order to relieve lower back pain, we were going to have NSAIDs on a as-needed basis and also a heating pad. Those are 2 things that could help relieve lower back pain. Type 2 diabetes. When you have type 2 diabetes, you end up possibly developing a hyperglycemic, hyperschmolar state and not ketoacidosis. We're going to get back to type 2 and type 1 diabetes, and I'm going to break those down and explain the differences between those 2 a little bit further down the line. So what is myxedema coma? So although rare, it is life-threatening. It is an extreme form of hypothyroidism brought on by an abrupt withdrawal of thyroid therapy, acute illness, anesthesia, sedatives, narcotics, surgery, or hypothermia. The signs include a loss of consciousness along with hypotension, respiratory failure, hyponatremia, hypoglycemia. This is treated with levothyroxine, fluid replacement, maintenance of the airways and respiration, IV glucose administration, and corticosteroids and warming measures. So severe underactive thyroid, severe form of hypothyroidism. A couple things that cause this: stopping thyroid therapy, abruptly stopping the steroids, causes things like that, throwing off the production of the steroids. Acute illness can cause this. All of the things, I'm not going to repeat them, but those are the things that cause myxedema coma, which is a form of hypothyroidism. So then you have the opposite of myxedema coma, which is a thyroid storm. And this is a form of hyperactive thyroid. So the opposite of a myxedema coma is a thyroid storm, which is an extreme form of hyperthyroidism. This is brought on by the removal of the thyroid gland via thyroidectomy, also an administration of drugs or dyes containing iodine, pregnancy or childbirth, myocardial infarction or cardiac emergencies, severe emotional distress, trauma, or surgery. The symptoms of thyroid storm are characterized by a sudden and extreme elevation of all body processes. Temperature rises up to 106 or more, pulses increase up to 200 beats per minute, blood pressure elevates, respirations become more rapid, and the patient becomes restless. So see how that is the opposite of hypothyroidism and the opposite of a myxedema coma? You have hyperthyroidism and now possibly going into a thyroid storm. A thyroidectomy, like I said earlier, could possibly cause hypothyroidism. If you take the thyroid out, you can have the opposite effect, which is hypothyroidism, which is why medications for hypothyroidism would be needed if you ended up taking the thyroid out via thyroidectomy. But when it could also cause the opposite effect, when the rest of that thyroid tries to compensate for the thyroid that is now missing, now causing the thyroid to go completely overactive and elevate all of the body processes, which is causing all of these crazy symptoms like a temperature of a 106 or greater, BPM up to 200, and blood pressure elevations and becoming rapid and things. All of these things because the thyroid is now trying to compensate for what is now missing, causing things to be way overactive. So, moving on. Addison's. When you have too little steroids, this is a condition known as Addison's. Addison's also is characterized by too little sodium and also too much potassium. Because remember, like I said, when you have too little sodium, you end up having too much potassium. So with too many steroids, the condition is called Cushing's. In this condition, you have too much sodium and not enough potassium. So let's talk a little bit about fractures. Green stick fracture. A green stick fracture is when the bone is half bent and half broken. A comminuted fracture, and this is when the bone is shattered into pieces. A closed fracture, and this is when the fracture has broken, no skin. Bone is broken, but no skin is broken. An open fracture, and this is when the bone is broken, but you have broken the skin, and now we have an open fracture. How many weights are used for skeletal traction? With skeletal traction, there should be 10 pounds or more with the weights. For skin traction, no more than 7 to 10 pounds. The rheumatoid arthritis test consists of RF and a C-reactive protein. Rheumatoid arthritis is associated with massive inflammation, warmth, tenderness, and pain. Also a big issue with pain. Always a big issue with pain with rheumatoid arthritis. That is one of the main things that is characterized by rheumatoid arthritis. The nurse's job with internal fixation would be to make sure that the pins are clean and dry. Compartment syndrome. Let's talk a little bit about compartment syndrome. With compartment syndrome, if the patient has an injury on their leg and the nurse observes decreased pulses at their feet, what is the first action? Your first action is going to be to call the doctor because you have a circulatory compromise. Compartment syndrome is increased pressure within a limited space. The fluid accumulated in the tissues and impairs tissues perfusion. The muscles become swollen and hard, and the client reports severe pain that is not resolved by pain meds. The pain is disproportionate to the injury. If undetected, it may result in severe nerve damage and possible amputations. The common areas include the forearm, the quadriceps, and the tibia. So this is pretty much when you have an increased pressure within like a really small space, and then the tissues are not able to perfuse because the fluid is accumulating within the tissues, and then the patient starts to experience pain and muscle swelling and hardness, and then now you may have to possibly have an amputation. If you are dealing with the cast, you are going to want to loosen the cast in order to improve some of the circulation, but you definitely cannot remove the cast because you are not the surgery. You want to notify the doctor and get the doctor's order on what to do next, but you definitely, if you can, loosen up a cast to let some circulation get in a little bit better because we have a circulatory issue with compartment syndrome. For some hypoglycemic meds for type 2 diabetes, you have some glyburide, some repaglinide, and some rosagiltazone. Okay, rosagiltazone. Okay, so as y'all know, medications are extremely hard to pronounce. You have to really sound them out. But you have glypurides, repaglinides, and rosagiltazone. Tried my best. Let's talk a little bit about sprains. So what is a sprain? A sprain is a partial or complete tearing of the ligament. The sprains are broken down into grades. You got grade 1, which is mild, a grade 2, which is moderate, and a grade 3, which is severe. So with grade 1 sprains, you are going to experience tenderness, swelling, no loss of function, and a microscopic tear of the ligaments. For grade 2s, which are moderate sprains, you're going to experience more severe pain, swelling, some bleeding into the joints, some loss of function, and a partial tear of the ligaments. For grade 3, which is the most severe, pain may be less severe with the grade 3, but you're still going to have swelling, loss of function, bleeding into joints, and a complete tear of the ligament, producing instability of the joints. So those are the differences between the 3 different grades and the ways that sprains are rated. The way that you're going to want to treat a sprain, there's an acronym called RICE, and the acronym stands for rest, ice, compression, and elevate. You're going to want to do this for 24 to 72 hours. Ice for 10 to 20 minutes out of the hour for 1 to 2 hours every hour during the day. NSAIDs around the clock. Those are going to be the ways to treat sprains. So let's get into diabetes. Let's get back to diabetes. So, a diagnostic test for the diagnosis of diabetes mellitus. Now we're talking about diabetes mellitus. Diabetes insipidus was when we spoke about the decreased production of the ADH, which was leading to a copious amount of diuresis, which is urinating, and, a issue with the kidneys and not an issue with the pancreas, which is what diabetes mellitus is. So a diagnostic test for the diagnosis of diabetes mellitus includes a random glucose level greater than or equal to 200, a fasting glucose level greater than or equal to 126. A fasting glucose is before meals. A hemoglobin A1C level greater than 6.5. The hemoglobins are ranged within like the last 6 weeks or so. A glucose tolerance test revealing a postprandial glucose greater than or equal to 200, 2 hours after 75 grams of glucose is administered. And the glucose tolerance test is after meals. Some confirmation of diabetes with hemoglobin if above 6.5. The normal range for hemoglobin should be 4 to 6. Hemoglobin A1C, to be exact, should be 4 to 6. Pre-diabetic is 6.5. Type 1 diabetes. This is when the beta cells do not produce insulin. It is autoimmune. Signs include extreme thirst, which is polydipsia, extreme urination, which is polyuria, extreme hunger, which is polyphagia, rapid weight loss, irritability, weakness, fatigue, nausea, vomiting, fruity smelling breath. They will always need exogenous insulin because there is no endogenous natural insulin being produced. For type 2 diabetes, this is when the cells are resistant to insulin. This is modifiable. Signs include possible polydipsia, polyuria, polyphagia, excessive weight gain, a family history of diabetes mellitus, poor healing from scratches, blurred vision, itching, drowsiness, increased fatigue, and tingling numbness in the feet. Tingling numbness in the feet. So those are the differences between type 1 and type 2 diabetes, which pretty much type 1 is type 1 is an autoimmune disorder where the beta cells are not producing any insulin. They're always going to need insulin because their body is not naturally producing any insulin. Type 1 diabetes could experience ketoacidosis if, their insulin and their blood glucose are not properly controlled. Whereas type 2 diabetes is the one where it is modifiable, normally brought on by weight gain, family history of diabetes, a poor diet, excess sugar in the diet, excess sodium in the diet, but the insulin is not that the body is not producing any insulin or the insulin is not going into the cells, it's just that they are more resistant. And These people don't always need insulin. It is kind of like on an as needed basis, but they might be more on an oral metformin or like a more oral glycemic control type of drug. Pheochromocytoma. Pheochromocytoma. This is a condition where a rare tumor of the adrenal medulla that secretes catecholamines, which is epinephrine and norepinephrine. The tumor is usually benign, but shows malignancy in about 10% of cases. Causes severe hypotension. If left untreated, can lead to death. Signs include excess catecholamine release, severe tachycardia, and hypertension. Headache, palpitations, nausea, weakness, and pallor may be present. Diagnosis, diagnosed by the measurement of serum catecholamines and 24-hour urine measurement of catecholamine metabolites. CT and MRI may be used to locate the tumor. We are at the last bit of the study guide. We're back to the anterior pituitary, which produces the body's natural steroids. The pituitary talks to the ACTH, which talks to the adrenal cortex, which talks to the glucocorticoids, which then releases the cortisol, which is the body's natural steroids. When you have a goiter, this is a severe form of hypothyroidism. And this is pretty much when you have like a very big swelling on the neck of the patient. And this pretty much happens when, this could happen from like excessive iodine or just like, let me show y'all guys a picture. Like excessive iodine is pretty much like a severe form of the hyperthyroidism. And it looks really, really bad. If y'all could see like the swelling and things like that, it looks really big. And so when you have a patient who has that, that is a severe form of hyperthyroidism. You're going to want to keep them in high followers. You're going to want to have a trach and suction close by. They are at risk for aspirations and having respiratory issues and breathing issues. They have a difficulty swallowing, so they're going to be put in PO. Possibly may have a thyroidectomy in order to remove the thyroid for an overactive thyroid. And then we get into all of these other things that are possible if you remove the thyroid. You want to keep the patient in high followers after a thyroidectomy and keep the patient in semi-followers after the removal of the pituitary. So that is my study guide for the endocrine system and for the musculoskeletal system. And this is what I use, which is an outline of my teacher's lectures and an outline from information from the chapters that we were covering. And I must say, all that reading and all that studying paid off. Your boy got a 98 on that exam, and I shocked the hell out of myself, shocked the professor, got the highest grade in the class, and very proud of myself, very proud of myself. But I want to continuously study, continuously come on here and present the information that I am learning in order to help me study and, you know, related information out to the public as well, because some of this information could be useful to someone in nursing school, someone who needs like a study partner, or someone who needs some help with some of the body systems for whatever class they're in. Currently, I'm in Med-Surg 2 right now in term 4, and I cannot wait to graduate school, but this is the journey, and I'm like a little bit late in the game coming on here. I should have been posting and recording my study sessions so that I can go back and listen to myself, and so that I can speak the words out loud instead of just reading them on my paper. And when you actually speak them out loud, it helps you understand processes a lot better versus than you just reading it over and over. I would also recommend practice tests with rationales. Practice tests with rationales break things down in a way that you critically understand information. But yeah, this is my first recorded live study session, and I think I'm going to come back on here tomorrow to record my pediatrics test study session, because this was for Med-Surg 2, endocrine system and musculoskeletal system. I have a lot of things that I have to go over for pediatrics, and I have a lot of notes that I got to take from out of the books and from out of the readings, and I also have to like go back and listen to some of the professor's lectures. But once I do those things, I will come back on here and present the information again and make this like my little thing, man. So yeah, I'm Nurse Gene and a PN student, not a nurse yet, but I'll be back tomorrow, possibly. See y'all next time.